So as we are just sorting this out, we'll move on to the next talk, the non-surgical management, role of AGMs, anti-VEGFs, and lasers by Dr. SHREYAS. So over to you, SHREYAS.
Good morning, one and all. I'll be discussing on medical management in glaucoma secondary to posterior segment disorders. So, as we have already seen, mechanisms in these glaucomas can be either neovascular, inflammatory, angle crowding due to pushing of lens iris diaphragm or pupillary block, or trabecular meshwork clogging. But most often it is usually mixed mechanism glaucomas which we see in this subset of patients. So how to deal with this glaucoma secondary to posterior segment disorders? We have to control three eyes. The first eye is the mainly ischemia is the main cause, culprit, treat the cause of ischemia. The second eye is control of intraocular pressure, and the third eye is controlling inflammation. So coming on to management of the first eye, ischemia management. So we have to recognize the ischemia in certain disorders. So in PDR and ocular ischemic syndromes, which are some of the common causes of neovascular glaucoma, the time of onset of NVG is unpredictable. But in CRVO, in the pre-anti-VEGF era, they used to say that it's a 100-day glaucoma and the maximum risk is seen in first 7 months. In anti-VEGF era, it is no more 100-day glaucoma. The anti-VEGF therapy may reset the clock of NVG onset, extending the risk beyond 7 months. So two things which increase the risk of NVG are poor vision and presence of RAPD, which favor more towards an ischemic CRVO, and hence an undilated pupil examination is mandatory at every visit to pick up early NVIs. So coming on to ischemia management per se, we have three treatment options. The retinal laser photocoagulation, which is the mainstay of treatment, anti-VEGFs, which are used as a temporary adjunctive therapy, and retinal cryotherapy, less often used these days for recurrent NVIs. So coming on to retinal laser photocoagulation, it is a treatment of choice wherever retinal ischemia is the cause of NVG. It reduces the VEGF load. It is indicated in all stages of NVG. It prevents further angle new vessel formation and it prevents goniosynicate formation. It also cuts off the angiogenic stimuli and enhances the success of trabeculectomy. Hence, it is preferably better to do PRP before trabeculectomy, at least 1 week prior. So preferably, we have to wait for 3 to 4 weeks before planning trabeculectomy. So what about role of prophylactic laser in CRVO to prevent NVG? So CVO's study said that the prophylactic PRP does not totally prevent NVI or NVA, and prompt regression of NVI or NVA happens when PRP is given after the onset of NVI or NVA. So Harry et al. Have also said that the risk of NVG is seen only in a very small proportion of CRVO patients, and prophylactic PRP destroys peripheral fields in already compromised central vision due to macular edema and macular ischemia. Hence, there is no role of prophylactic laser in CRVO to prevent NVG, and only once we see NVI or NVA, we have to do PRP. So coming on to treatment protocol for PRP in NVG, special things which we should see in when we are treating NVG when we are doing PRP in patients with NVG is that we have to do little tight PRP. So usually when we do conventional PRP, the spacing is about 1 spot size, whereas in NVG, ideally it should be very tight, half spot spacing is advocated. So number of sittings is 2 to 3, and number of final burns is 1500 to 2000, which is approximately 500 more than the conventional PRP. So red laser can be used in the presence of hazy media. So in conventional PRP, it is up to the equator, but in NVG, to whatever extent we can see the retina, we can do the laser. Sometimes we can also use indentation and do laser using laser indirect ophthalmoscopy. So coming on to endo laser, it is used preoperatively during PPV. It is useful for cases with media haze like vitreous hemorrhage. So one more gonio-photocoagulation. Here direct laser treatment is done to prevent development of NVG. It was suggested as an adjunct to PRP in the pre-anti-VEGF era. It is largely replaced by anti-VEGF therapy these days. So coming to adjunctive therapy, anti-VEGFs, they have two important roles, anti-angiogenic and anti-fibrotic properties. Bevacizumab is most commonly used. Others include ranibizumab and aflibercept. Regression of NVI and NVA occurs in 1 to 7 days after the injection. They are used as adjunct to achieve rapid regression of NVI, and however, PRP remains a definitive treatment. So they can be delivered both by intravitreal or intracameral. Intracameral is easier to perform for most of the anterior segment surgeons. It leads to rapid regression of NVA and better IOP control. For patient planned for trabeculectomy, intracameral may be preferred. Dose is bevacizumab 1.25 mg, ranibizumab is 0.5 mg per 0.05 ml. So this is a case where you can see on the right image, you can see that there are profuse NVIs. After 2 days of ranibizumab injection, there is complete regression of these NVIs. So coming on to preoperative anti-VEGF before trabeculectomy, giving anti-VEGF before TRAB reduces the risk of postoperative complications like hyphema. It also increases success and helps to achieve better short-term IOP control. So coming on to third important thing in management of ischemia, the anti-retinal cryopexy. It is done less frequently these days. Current applications include during PPV when we need to ablate the anti-retina, which is inaccessible to laser, and for recurrent NVAs after adequate PRP. So the procedure is that we follow the rule of 8. 8 spots per quadrant for 8 seconds and approximately 8 mm from the limbus. That is, we put 2 rows anterior to the equator. So the next step in management, dealing with the second eye, IOP management. IOP management in the secondary glaucomas, aqueous suppressants are the drugs of choice. Oral and topical carbonic anhydrase inhibitors, topical beta blockers, and alpha-2 agonists can be used. Prostaglandin analogs are not that preferred because they may aggravate inflammation, and also the neovascular membrane may prevent the aqueous access to the uvascular outflow pathway. It is used only when IOP is not controlled by other medications. Osmotic agents are used intermittently to control extreme high IOPs and to clear cornea to facilitate PRP. Myotics are better avoided because they may increase inflammation and worsen synovial angle closure. Coming on to laser cyclophotocoagulation, the end-stage procedures for management of glaucoma. The mechanism of action is that it has 2 roles. One is permanent by direct thermal destruction of ciliary epithelium, seen 4 weeks after cyclophotocoagulation. Transient effect is seen immediately by inducing inflammation and decreases in aqueous production and increase in uvascular outflow. Laser cyclophotocoagulation are of 2 types, transcleral and endoscopic. Transcleral is again of 2 types, conventional and subliminal. First, we'll see about conventional DLCP. Here, a diode laser is used. It is done using either a G probe. If you don't have a G probe, we can use this sclerotic scatter. We can use a vitrectomy endoilluminator, which is used at limbus to generate a sclerotic scatter. And marking is done at the junction of the lighter and the darker area. And the laser is given at this junction. So coming on to conventional DLCP settings, the power is started usually at 1750 to 2000 milliwatts for 2 seconds. We have to increase by 250 milliwatts till an audible pop sound is heard, then turn down the energy by 250 milliwatts and then proceed with the treatment. Usually 6 applications are done per quadrant. We do up to 180 to 270 degree. We have to avoid 3 and 9 o'clock positions. So coming on to complications of conventional DLCP, it is associated with high chances of inflammation, hypotonic, pain, conjunctival scarring, CME and vision loss. So we currently follow this subliminal cyclophotocoagulation, which is relatively much more safer. It uses series of brief microsecond pulses with on and off duty cycle. The on time generates the heat sufficient to coagulate the target tissues, and the off time allows cooling, and the heat does not reach the adjacent structures, hence reduces collateral damage. It is associated with reduced complications and can reduce IOP by almost 30% in various types of glaucomas. So the parameter, again, it uses diode laser. The power is around 2000 milliwatts. Duty cycle is 31.3%. Treatment duration is 160 seconds, 80 seconds in the upper part and 80 seconds in the inferior part of the sclera. Here the tip of the probe is positioned 3 mm posterior to the limbus. The probe should be held perpendicular to the eyeball. The tip is then continuously moved in sweeping motions to deliver the laser treatment from 9:30 to 2:30 clock superiorly and 3:30 to 8:30 clock inferiorly. So last one, the cyclocryotherapy. Here, sub-zero temperatures of cryotherapy is applied to freeze the ciliary body tissues, leading to destruction of ciliary epithelium and hence decreased aqueous production. It is usually indicated these days for painful blind eyes, and it has been largely replaced by laser cyclophotocoagulation. The extent of treatment is usually 180 degree, 5 to 8 applications are given. In seeing eyes, it is usually avoided. 360 degree is never done due to high chances of complications. The procedure, we use a cryotip of around 3 millimeters, which forms an ice ball of 5 millimeter. It is performed under local block only. Placement around 2 millimeter from the limbus. The cryoprobe is firmly placed on the sclera and freezed for 60 seconds. And slow thawing is allowed. Post-procedure, we have to give topical steroids and cycloplegics and systemic NSAIDs for pain management. Anti-glaucoma medications are continued till the IOP reduction is achieved. Coming on to the third eye management, that is inflammation control. So inflammation control, steroids remain the mainstay of treatment in inflammatory glaucomas. Topical steroids reduce congestion and inflammation and also help to regress NVIs and NVA in patients with NVG. Systemic steroids are reserved for non-infectious intermediate and posterior uveitis, can also be used for glaucomas associated with choroidal effusion. So last but not least, cycloplegics. The role is that they reduce uveal congestion, they break synechial and occlusive pupillae, it pushes the lens iris diaphragm posteriorly, and it is used as adjunct treatment in inflammatory glaucomas, neovascular glaucomas, malignant glaucomas, and in choroidal effusions. Thank you.
Thank you, Dr. SHREYAS.